The Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between. Well, hello again. Welcome to the Pediatric Lounge. This is your host, Dr. Herb Bravo, and joining me today is our host, Dr. George Rogu. We have a wonderful guest who is a medicine and pediatric specialist and who has done multiple jobs both as a physician inside the hospital, outside the hospital, in industry such as health plans and pharma, and now is working with a new company that's helping support independent practices to survive and thrive in the age of managed care, the new managed care, where attribution and value-based contracting becomes very important. Please help me welcome Dr. Munish Khaneja to the show today. Hi, George. I'm here broadcasting today from one of our peeps in Peds United web server, Dr. Brian, who's vacationing in Aruba. So I'm in Manassas, Virginia. How are you?
I'm doing good. You're living the life of Rogo, I see, doing podcasts and actually seeing patients. Today's another Tuesday, and we're elevating another great physician, a very dear friend of mine, Dr. Munish Khaneja, who's going to tell us a little bit about clinical medicine and corporate medicine. And his topic is going to be working for the healthcare machine while advocating for medical practices. Pretty cool topic.
Well, welcome to the podcast. Where are you joining us from today?
I am joining you from Long Island, New York.
Wow, near George.
Yep.
George.
It's a pleasure to have you here. We always like to start the podcast by asking the physicians that join us, why did you become a physician, and particularly med peds? Is that even a specialty anymore?
It is still a specialty. I became a physician mostly because coming out of high school, there was a science interest, right? You know, I grew up at a time where there was always this science engineering mindset in my family. My dad is an engineer, so which one of these made a lot of sense? My sister's also a physician, so that was kind of the other influence, and I liked science. Just that was it. Couple of personal things that happened along the way where doctors were very, very instrumental in helping family members. So you put all of those pieces together and suddenly you basically decide this is the field I want to go in. So medicine became the direction that I definitely did want to go in. That being said, I found medical school rote memorization one of the hardest things. I didn't understand why I had to memorize all of these things. And it wasn't until residency that I truly understand when you applied all of this to a patient sitting in front of you, the analysis that you actually have to work on. That's when it became interesting. Why med peds? That was really simple. Went through all the rotations. I could not choose. I absolutely loved the thought process around internal medicine, where you really have to work through complicated situations with patients. And I love the humanity around pediatrics. I think it was just really important because you're not only taking care of the patient, you're taking care of the family. And it's just too much fun not to do. So that was why I decided med peds was good for me. At the time I was doing this, med peds was a very, very big specialty. It still is. You still have about 150 programs across the country. The general residency number is anywhere between 2 and 8. So it's a pretty functional sized residency program across the country.
Yeah, I like the med peds programs. I think they're unbelievably well trained. And
it's the OB piece. If you're not interested in the OB piece, if you have OB interest, then you move over to family practice. That was the piece. Since I didn't have that interest, it was perfect.
And there's such a need, because that, I don't know, 17-year-old to 35-year-old healthy person really has nowhere to go. The true intern is just too busy taking care of the 50 plus with all the chronic illnesses. And right. they end up in the urgent care where they don't really get great care. So wonderful. And how long did you practice as a pediatrician internist before you decided to change over to population health?
about 9 years, a combination of first moving over to federally qualified health centers. So after those two residencies, you believe it or not, I did a third residency in public health preventive medicine. I wasn't like George or you, who was kind of business minded enough, or maybe directed to a private practice mindset. Opening up my shingle was not in the cards, but I did like the program development. So another interest that developed along the way was, how does this happen? How does the money come along to take care of the work? Also had a very keen interest in the epidemiology, the biostats around it. So I decided to go and do public health preventive medicine residency at Stony Brook. Putting those three together, the first job I got out of my training was a CMO at a federally qualified health center. So just the most interesting place to jump into, half-time clinical and half-time administrative from the get-go. So we have like 10 doctors working for me at that time.
Oh, wow.
And just amazing. But here's the piece. That was a little early for me to cut my teeth in administrative, because I hadn't done the time of really seeing patients. So it was great. Did that for about 3 years in upstate New York. Decided then, well, I've got to strengthen my clinical piece. And I had the opportunity to become a med peds hospitalist back at the place where I trained, which was Kings County. That was where I went to college. That was where I went to both med school and residency training.
Right. I see a lot of people, physicians especially, they kind of resent the admin people because they feel that they're not walking in their shoes. So it was good that you were doing like some clinical and some admin, not just full admin. But it does take a long time to get to that admin piece without, I mean, you have to do clinical first and then become an admin, but you have to be like half and half.
Yeah, we have a saying. It's called street cred.
Yes, basically street cred.
I have to absolutely tell you, in the time when I was at the FQHC, even being a part-time admin, part-time doc who saw patients, it wasn't enough street cred, because I didn't have enough patient care. Hypertension, diabetes, how many different things were going on. It wasn't automatic yet. And I think that automatic ability to walk back to a clinical conversation is the way a doc talks to another doc. It's what grounds us early on.
Yeah, because I have medical students from Nikon that come over, and when they hear that I have an MBA, they say, well, I want to get an MBA. When should I get an MBA? And I always guide them and says, do clinical medicine for a good decade plus. Mm-hmm. When you're like 40, 45, then go for it.
Yeah, after I am absolutely agreeing that it should be after your MD, after your residency. How far after your residency you decide, but completely agree with you on that.
I think any industry will tell you that the best MBAs that come out have deep-rooted experience in a field that they're already experts, whether you're an engineer or a data scientist, and then you go get an MBA. But leading people is extremely difficult.
Oh yeah,
it's amazing. It's amazing that you went from the residency to being a CMO, because leading people is not easy.
Especially doctors.
Especially doctors.
I don't know. Have you ever tried to lead a group of engineers?
I think that's always hard. It's always hard.
Leading people is very hard, especially when they have great technical skills, right? Whether it's an engineer, a data scientist, a nuclear physicist, it's not an easy, they're very smart people, and it takes a lot to lead them properly. Fascinating. So do you do any clinical medicine right now, or are you fully admin?
No, I made that decision. So this is another interesting piece. There are people who still have the ability or desire, whichever one or both, to still work maybe one shift a week, one timeline. There are specialties that allow for that. ER, right? ED training, where you could still do one shift a month or 4 shifts a month and then go back to work, doing on the admin side. That lends itself to a finite, shorter set. My problem with continuing on in clinical medicine was there would be 4 patients or 5 patients I would call my own, basically one session a week, or I'd be covering other docs. And at the end of the day, that's not my patient. So I can't really do a longitudinal process, which is what internal medicine and peds, it's watch them grow, see if the hypertension is treated. You can't do that with 1 session a week. I couldn't do that. I didn't feel like I was giving enough time to the art of medicine. So I decided that it's better off to have somebody who can be a physician to support the other side. My interest in switching over to managed care after, and I'll talk a little bit about that now, is my interest in switching over to managed care came from the fact that the average doc that was a CMO of a health plan when I moved over was a 60 to 65-year-old surgeon at the end of their career.
Right.
That's not somebody who understands what the doc's going through. I kept on feeling like I'm looking at these CMOs at all these health plans, and they're talking ethereally. They're talking, well, the business side of it is important, and we'll keep talking about that, but you don't understand. It's that street cred that was missing from those docs.
Yeah.
So that decision to change over made more sense to me. Absolutely, honestly, lifestyle was important. A med peds hospitalist is a busy, busy practice time. You're always on the floors. There's a 5 to 7 year classic burnout timeline with the hospitalist. I hit it at exactly that time, and this just made sense. And I had an alternate set of skills and an alternate desire to help it a different way. So that's why in 2010 I actually decided to stop seeing patients.
And tell us what your day is like now that you're not seeing patients.
What my day is like now, or when it was when I moved over in the health
right now that you're
well, now I do something different. So we'll go back a little bit and kind of describe through the process. So as a health plan doc, a lot of your time is spent building out policies, because basically you have to have a backing for everything you do. I know docs don't like having policies thrown in their face, or they have to go on a website and find those policies. But if those policies aren't clearly written, you, the physician who's asking for a prior authorization, or who wants to understand why we say yes or no to a process, or you want to understand how we're credentialing, why sometimes we had docs who had like 5 cases against them. Is that automatically a reason you shouldn't be credentialed to a health plan? No, you should understand what happened with the cases. There's a dollar value of the cases in New York. You have $8 million, $10 million lawsuits, which can be even considered frivolous. So this just cannot be a doc that says, I think you shouldn't be in. I was always against that. So I spent a lot of my time writing and making sure there was clear policies to what we did. That was one. 2, a lot of my day was spent organizing around the clinical side of what we did. So we had docs who worked for us. A prior authorization request would come in. And again, they were coming up with, in my experience as a urologist, I had one medical director at the health plan who's a urologist, non-practicing anymore. Another one who was a pediatrician. And the 2 of them were our core medical directors. And then I was the third one who did all the cases, who anytime there was a prior auth request. And half the time in the beginning, they would just come up with responses on why they thought something should be approved or not, when there are clinical criteria engines nationally recognized. One is called MCG, another one is called Interqual. These are ones where people have sifted through thousands and thousands of pieces of literature to say, if a patient is admitted with chest pain, these are the 5 things you need to look for. If the 2 of you decide to admit a child with pneumonia, these are the core things you have to authorize. And it's not that we're denying the admission. It's that we're denying paying for a frivolous admission, which I always was against. The second piece to that is, since I trained in the inner city programs, one of my favorite sayings to my residents was, do you pay taxes? Of course I pay taxes. They were like, I said, so you really want to prescribe a brand name medicine instead of a generic, because this patient's on Medicaid that comes out of your tax dollar. And you really want to admit this patient when they really have a great social structure, they can go home, but you spent $8,000 to $10,000 of public money. That's what Medicaid is, public money. You spend $8,000 to $10,000 for an overnight admission when everything could have been done in hundreds of dollars, and you send them home. That mindset, especially having been a hospitalist, watching patients get admitted, didn't sit well with me. But all of this has to be backed with science. So I spent a lot of my time applying that.
I'll push back to you a little bit, because you were a hospitalist. So you saw them on the receiving end. Being in the ER is not so simple. You don't know the social structure. Do they have access? Do they have a follow-up? Can you get an appointment with a follow-up with a physician? They don't know sometimes. So I remember from my days in the Bronx, you just put them in to see what will happen tomorrow, and then tomorrow you square it away.
So again, I'm not saying that you don't have to admit the patient, but a health plan has the ability to then make that decision about payment or not. Now, why the piece, I'll push back the other side. We made sure at Kings County, when this was a problem, we had a social worker on for both pediatric ER and for adult every day. We had a day, evening, night, everything shift. So we said 3 a.m, if this is a patient who we think we had an ability to send home the next morning, hold on. Obviously, 3 a.m. is hard to go on. We had a bed available, 5:30, 6 o'clock in the morning, get transportation ready, get them home. So we did figure that out, because there is more and more of a pushback. And I get inner city is much different. The uninsured patient is not the one I'm talking about. That's not a situation, but in an insured patient where they have transportation as a covered benefit, you literally could send a patient home. At that time, wasn't Uber. These were actually ambulettes. You could send them home. So people see, but you're exactly right. You automatically make the assumption that there's no infrastructure. It's there. We don't use it enough. Now we talk about it all the time with social determinants of health. It's everywhere. 15, 20 years ago, we weren't using it.
Right. Well, nobody knew about it, I guess. And I mean, how do you get a cab in the emergency room at 3 o'clock in the morning?
You don't. You're totally right. So you get the social worker to make sure there's no other issues, write down their assessment. They then come down and write down their assessment, just like we worked hard to make sure the patient's clinically stable. Go write your assessment, put it down. If the person's good, 2 hours, hang out in the waiting area. 6 o'clock in the morning, we'll send you home on the ambulance.
I think there the problem is that what I think of the evil empire is the health system. It's not in the best interest of the health system not to admit the patient. So they're not going to teach doctors their training or invest in the social work component in the ER so that you can get these patients home safely most of the time. They want the patients admitted. They want the beds filled. They want the CT scans, the MRIs, and they're constantly pushing you as a resident, and as a contract doctor to produce. And how do they measure your production? Is by amount of spend. So that's how health systems measure. They could care less. I was a pediatric emergency room doctor. What they cared about is that I had a spend that was similar to the orthopedic surgeons. So they were happy to pay for my salary and my 4 colleagues that worked with me, because we ordered tons of tests, because we're ER doctors, right? So we got to make sure every head that hits the ground gets a CT scan before I send them home, because we don't want to get sued. In the office, I don't do anything with them. I see them next day, right?
Exactly right.
So it's that negative loop. That really is who is responsible for a lot of the spend in healthcare in America, is the health system. So I want to talk a little bit about how did you go into value-based care and population health? What is that, and how did you know that was going to be the future?
I would love to say I planned this. No, I think I had always had a absolute desire to learn more and more. So that constant interest in, and I think most physicians are this way. You have to be, otherwise you kind of get stagnant quickly. The constant desire to learn a new set of skills was the driving force of moving from clinical medicine and then moving over to seeing patients, moving over to the value-based care side at the health plan. So I think the biggest piece where value-based care came in is right around 2012 to 2014. There's a company called Healthcare Partners, not the one we talk about in Long Island. It's actually another one that was built out of Vegas and California. And they were the ones when Medicare was first starting to do risk adjustment, where basically the Medicare system pays the health plans based upon how sick the patient is. Because logically, it makes sense. You can't give a health plan the same amount of money to take care of a patient who's super sick and is spending 15 to 20 times the amount of a very healthy Florida active Medicare patient, right? We could use different examples. So in 2008 onward, the Medicare system started to do what's called risk adjusted payment. Healthcare Partners was a company that said, okay, wait a second, let's make sure we understand how we code, how we're taking care of these patients, and keep costs low as well. That company sold for $6 billion.
Wow.
$6 billion at that time, to DaVita Health, which a whole different story about how they did that. A kidney company decided to buy them. But the more important piece is they built a value-based care model. Make sure that you are coding and understanding how the payment system works. That was also true for New York Medicaid. Even New York Medicaid pays the health plans on a value-based care structure that's however sick the patient is, you get a little bit more money. Very logical, because you got to pay through the system. It makes sense. On the other hand, the cost control pieces was where, when I talked to you about the beginning of this, my way of cost control is making sure it's scientifically supported admission reduction, have care management. So part two, if you don't have support in your one doc practice to take care of the patient, it's incumbent on the health plan to hire up care managers to support you. That's what we do. I would love to do more of that. And I'll kind of explain to you that the reason I moved out of the health plan world was because that's as far as we got. You would call us for prior auths, you would call us to get paid. But when we wanted to intervene, the patient's sitting there saying, who the heck are you? You're a health plan nurse. They're not nurses that are coming from the doctors. So one of the pieces that I thought was, okay, so what's missing here? Well, what's missing is the right mind of helping to control cost in the system. I got that out of the health plan world. The ability to control the dollar, right? You got to follow the dollar and see where you can get it. So this way we could do a good job getting more money into the health plan's hands. And because we were a not-for-profit health plan, we weren't out there to make major profits. You just need to basically cover what you have. Everyone gets a good distributed bonus and we all go home a little bit happy. This is one of the mindsets was fine. The problem was we were never able to get close enough to the patient. As a health plan, you're not able to do that. They'll spend millions of dollars talking about how we're here for this patient, we're here for that patient. It's not in the design. When a phone call comes from George Rogu or Herb Bravo's office and it says, this is coming from your office, the patient will pick up. The patient gets a phone call from Affinity or gets any kind of paper from Affinity, it goes in the garbage can, or it never gets even picked. No one even goes and listens to the message. That's the problem with the way we have healthcare. So moving into value-based care was an interest. I took a little detour along the way, after 6 or 7 years of health plan time. I enjoyed it thoroughly, learned, again, another batch of skill set. After Affinity, I was able to go to Emblem Health and do a lot of the same stuff on the medical management and pharmacy side, learned all about the pharmacy cost in medicine at that time. So again, the learning experiences were great.
Let me interrupt you there a little bit.
Okay.
It makes no sense to me why we're managing pharmacy when you can get, say, for example, amoxicillin for an ear infection for $5 if you pay cash. Why are we trying to manage $5 transactions? I buy my Lipitor, and maybe I shouldn't be telling the people, but I take Lipitor, and I can buy a 90-day supply with GoodRx for $14. Why on God's good earth would I want a third party and an insurance company involved in that transaction? It's only going to increase my cost.
Every good system, every good business model finds a middleman. Let me use a great example. Buying a car. Why don't you just go to Volvo? I have a Volvo. I like Volvos. Why don't you just go to Volvo and say, give me my car? Literally, international. Well, you can't, because the middleman is the car dealership. Mm-hmm. Every system will find a middleman. In healthcare, pharmacy, the middleman or the pharmacy benefit managers. So what they said is, your one amoxicillin is not what I'm going to work on. Let's use your amoxicillin example. It's a generic. Let me use a better example. You remember some of the Elidels, right? Remember all of the original tacrolimus, picrolimus?
Yes.
When they first came out, these were the branded atopic derm meds, right?
Right.
You could give steroids, obviously you have discoloration. There's other reasons to give these medicines. They work. So let's go back to a time where I remember Elidel first comes out. The PBM says, I'm going to go to the manufacturer, and not just for one health plan, which is 1,000 scripts. We're going to go to 30 health plans, which is 1 million scripts. So when the manufacturer sees somebody who can control access to 1 million scripts a year, they're going to work a rate structure. So what do? Figure out a way to get right in the middle of that. you make a little money from the manufacturer side, you make a little money from the health plan side, suddenly you made a lot of money. And that entire industry was based upon that. Now, because you, as an example, hate it, the good RXs of the world, there's a single care pharmacy card. There's a whole host of ways where people have said, we're not going to deal with the PBMs in the world, PBMs anymore. In our Trump administration, one of the biggest things they pushed was pricing transparency on pharmacy, on Medicare. So we are in a world where what you just said, Dr. Bravo, I don't think it'll survive the way it does. And in fact, it hasn't. If you've been following it, CVS and Aetna's merger is actually an interesting one where a pharmacy and pharmacy benefit manager said, wait a second, we can't live on that revenue alone. Let's get Aetna's revenue and build it in under us. On the other side, Cigna bought ESI, the other big PBM. Magellan RX, the third one, has changed hands 3 times in the last 2 years. So this pharmacy industry is already being beaten up by inability to control the price. So pharmacy, it's the best middleman industry I've seen in 20 years. Very intelligently put together. Nothing that we benefit from. We're on the other side of it. No one makes money on that really, other than them.
Yeah, it makes no sense to me to spend time managing a $5 cost.
In pediatrics, you won't see that. The reality is when you talk about medicine, so Peds is a good example, and Medicaid is another one. You have about 1 script per person per month in Medicaid patients, most of which are pediatric patients. So you don't have a ton of usage. When you go to Medicare, you have 3 to 4 prescriptions per member per month. So think of the difference here. When you're managing 4 times and you have more branded and more expensive medicines, that's why it does come to become very expensive.
Right. So I agree. So you're having to prescribe some of these new medications that are phenomenal, makes sense to be able to manage the cost of them.
Correct.
And be using them properly too, right? So
correct, totally.
I mean, everybody doesn't need the latest antibiotic or whatever it is branded. So after Emblem Health, you went to Altrista Health.
Yeah.
What did you do there?
So that was my little detour. And I always had a little bit of an interest in health information technology. During my hospitalist days, I was the assistant CMIO at the hospital. Did a lot of work on building out the EMR because at that time, there wasn't everything is Epic. There was many inpatient EMRs all over the country at that time. In the health and hospital system, we were actually trying to build out going from paper to electronic. So I was fortunate enough at that time to be there to kind of help the docs translate what do they need. So I would go to the doctor and say, what does the process look like? For example, radiology procedures, ordering them. Where do you need to see it? What's the process? Medications, ordering them. What do you need to do? A discharge summary, these kind of core requirements. They weren't even built out in the EMR we were using. So I would then translate that to go to the developers at our own coders and say, here's how the process should look. So I would go back and forth, help train it. So I got an interest in health IT. That interest was always there and I understood it. So in 2016, after some time spent in the health plan world, a person who I had known and already worked with at Affinity, they had a system that was a care management system for health plans. So this was a clinical system where the prior authorization goes, where risk stratification, care management, all of the things I just talked to you about, the clinical side of a health plan, what they do. They had built a really well organized cloud-based platform for health plans. And they were asking me at that time, somebody who understood how doctors think, and especially how doctors and nurses think in health plans, can you be our CMO so we could help develop it even better for the need? Oh, and by the way, our specialty is Medicaid patients and dual eligible patients. And I'm like, this is perfect because now I get to, I joke about it. Whoever lets a doctor get this involved in doing things, use the time. Usually they put us in a corner or they say to you, just write the policy, do this. I got the opportunity to actually sit with coders and develop an entire care management platform for doctors and nurses and health plans. So the company was based out of Virginia. My first try at working from home, 2016, and I'm an IT CMO. So I was like, this is perfect. Let me just try this for a while and see what it's like. Ends up being, we're very fortunate. The company did well. As I left, there was 42 million lives on the platform.
Oh, wow.
Country.
But Dr. Munish, what I liked about you when I first met you was when you were the medical director at Affinity. You remember you created that program where you reached out to the physician's office. You walked into our office. You spoke to us. You told us what we should do. You told us what we should do to do good medicine, and then the money would follow.
Mm-hmm.
Right? Then you created that network physicians meeting where you brought in all the physicians of different counties and sat down at Affinity headquarters, and we just talked about stuff. That kind of stuff with you when you left, that was gone.
Yeah. Thank you for remembering that time.
So he's an internist and a pediatrician. He believes in relationships.
Yeah, it was great.
Relationship matters.
Travel an hour to come to see him and then go back to work.
Yeah.
Not just me, like 10 people.
That's the power of relationships.
Yeah. And then he left, and then that thing finished.
Yeah. So before we talk about what you're doing and care about, I want to level set a little bit, because this always confuses me. What's the difference between a single small practice, an IPA, a clinically integrated network, or a group without walls?
So let's go in that order. First and foremost, a single practice, you have a lot more ability from a negotiating point of view to organize well. So when a regulatory situation, when you have a practice of 5 docs or 100 docs, but they're all under one single tin, that's considered one practice, one mindset. And when you talk about attribution, right? So we'll come back to what that's really important. In this day and age, as we've moved from specialty-driven, cost-driven cost-driven healthcare to more value-based care, the value is built on no longer it's called a gatekeeper. In the 80s, it used to be you had to go back to your PCP. If you wanted to get a referral, you had to get a specific form written. It was a gatekeeper mindset, which was just utilization control, but it wasn't making it easier on the patient. So now it's, well, if you have a doctor who's an internist or a pediatrician where they have 1,000 patients where they are called the PCP, and it's the assignment in the eyes of the health plan that counts. So when the health plan sends you an attribution list, both of you seeing patients, you get a list every month called a roster from a health plan that says, these are the patients we've assigned to you, your practice, and then even some of your docs, if you have docs working under you. So the single tin is the strongest single connection that you can make. And if that's larger and larger and larger, that's better because it allows everybody to say, okay, this is one practice, one clinical guideline set, one way to practice. You don't have to keep proving clinical integration. The next level of work sits in what's called an IPA. And the IPA literally lets you take 100 doctors who are not in the same practice. They could be in 100 different practices, or let's call that in 100 different tins. And those 100 tins could go to a health plan and say, give us a better deal. Now, an IPA usually can just talk about core rate structures and maybe a little bit of quality upsides, what's called quality pay for performance programs. When you go back to a health plan and basically say, as an IPA, we want to be able to help you control the costs and the process more of the cost structure and improve the quality of these 100 different tins, the state regulators will say, well, are you colluding? Are you doing something that's Stark law issues? Are you doing, they'll just have too many questions about us getting together illegally. And the way that works is you actually create what's called a SIN, or a clinically integrated network. So what that means, in that IPA of 100 tins or 100 practices, all the pediatricians get together and create the pediatric subcommittee, and the pediatric subcommittee writes the clinical guidelines on how to take care of otitis media, how to take care of pneumonia, how to take care of allergic rhinitis. Like, you could come up with 10 or 20 of these, but it basically should show that these clinicians are thinking in an integrated fashion. Once you can show that, You are then allowed to go to a health plan and say, give us additional ability to control the cost. Oh, and by the way, if we control the cost, and let's say we save $100 for you, health plan, we get half of that, or a third of that, or three-quarters of that, whatever you've negotiated, which are called shared savings programs.
Is there much of that in pediatrics, or is it most pay per month per member based on if you achieve quality metrics? Because the spend is $2,000 per kid, right? So
yeah, it's improving a lot. I'll tell you where medicine, we thought it was not going to be. Pediatricians are absolutely important as part of a bigger picture of internal medicine in peds. When you have a large volume of patients, let's say you have 10,000 patients and you have 3,000 of them are kids and 7,000 are adults, the kids count. So they absolutely count in the bigger picture of attribution. Pediatrics alone, what's happening more and more, and what we're finding, quality measures, and Dr. Rogu's been like one of the best, I think, in the last 20 years that I've seen. The quality measures is not as much of a challenge anymore. Once you understand when you have to see the patient to do what quality measure, if you have a system to bring them in and they come back in, obviously a little harder in the uninsured and Medicaid patient group, but still doable. If you have a structural approach to get those pieces done, you can get the quality measures. The health plans are now saying, well, let's take 150 of your asthmatics. I don't know, Dr. Rowe, what's the attribution? You have 10,000, 20,000 attributed patients at least total?
Well, at what level? The RBK level or our CI?
RBK, let's call it at the RBK level.
RBK has 20,000 people.
Right. So you have 20,000 of your own. We're not even at the SIN level. We could take 20,000 of those patients and say, let's say 10% of those are asthmatics. Just pick a number. Let's say 2,000 asthmatics. So we could create a value-based care program that says, because RBK is so good at asthma, they have their own urgent care. Because RBK is so good at that and they've created a model, we will create a shared savings program on asthma. Also, we'll send more and more other patients who are not even RBK's patients to that group, because it becomes an asthma center of excellence. So there are places now more and more based upon your specialization, even in pediatrics, to box in a sicker subset of pediatric patients with complications and work on them. If it happens to be behavioral health becomes your specialty within your group, you could do that as an example too.
So tell me, I was going to ask you exactly about that. That's also the case for behavioral health, mental health in pediatrics, where they're carving out best, centers of excellence?
Yes, absolutely. Behavioral health is the hottest topic right now after social determinants of health. Behavioral health is the hottest topic. There's companies popping up left and right trying to come up with solutions. Some are coming up with risk stratification solutions. The biggest problem we're running into is, as an example, health plans have done a poor job of paying the rate that's really needed to do that. So there's a whole host of different ways to do it. There's value-based care. There's virtual medicine. There's companies out there that are saying, well, if the doc can't come to you, we'll take a room in your office and literally put a monitor with a pediatric neurologist or a developmental specialist or a behavioral health specialist, and just talk to each other, even if virtually. If they can't get out to you, we'll find a way for them to see you. So it's becoming more and more important. I think we have not done enough of a good job of training enough folks or paying them the value that they are. Hopefully that'll change soon, because I think it's time. But that's another one that's big.
We had a project with behavioral health in our office where we worked with one of the hospital systems, where they embedded a social worker in our office, and she would do counseling, and we immediately filled up her panel. Immediately. And then time went on and they couldn't do it, and they couldn't pay her, and then they killed the project because they couldn't make it work financially. So I think that's why nobody really is doing this.
Well, I'm going to push back a little bit there. So there are people who are doing this successfully, and Susan Zarota did it successfully. Leo Gino did it successfully. Gene Marconi did it successfully. And the key there seems to be the thread that they all tell you is it's focused, short interventions. These social workers, these psychologists embedded in your office cannot be what we think traditionally with the psychiatrist or the therapist, where you go once a week and spend 45 minutes with them, because there's so much volume that it cannot function that way. But where every pediatrician across America is scared about is, if I take care of a depressed kid or a kid with anxiety, first, I don't know how to do cognitive behavioral therapy. And second of all, I can't spend 30 minutes with a patient and get paid $55, which is what Virginia Medicaid pays, because I will be bankrupt in 3 months. And how do I bridge that payment gap? And until that payment level rises and we have time to learn about cognitive behavioral therapy to do those short 6 interventions, we're not touching the problem. But it can be done. It has been done very successful, but it takes a lot of effort to do that. I don't know what your thoughts are.
I think it absolutely can be done. The effort is, though, not just going to come from your ability to create a model. It has to be a sustainable model that can be reimbursed. So if you found it work with one plan, let's just say one health plan does pay enough, or you figured it out in a cash pay model, I would go to the next step and say, okay, how can we now scale this with 3 pediatricians and 4 behavioral health specialists? How do we scale this model and make it something that's useful for more and more patients in a region? There's great examples. And this is why I think I find it interesting, especially now that I work on the other business side of medicine, to watch the way private equity companies invest. There are so many companies trying to figure pieces out. And that's that right there's that point where they figured out, I can do this with 100 patients or 1,000 patients. Can we do it with 1 million? That's the test. So if you're finding something that's good, test it, PDSA it, see if it can build out. And then eventually, if it's a really good business model, sell it a little bit, build it up more and get some more funding to do more with it.
So what is Care about, and what are you doing there? I think this is going to be the most fascinating part of the conversation.
Right. So what do you do with all the experience? I think the first thing I'd said to you early on was what was missing through each of these experiences after my time seeing patients was, how can we support the doctors to do better? I think that desire to do better patient care, I feel like I was able to fulfill a lot of that during my clinical time and even at the health plan time. Organizing around something where we were having a dialogue with doctors, and when they were saying, okay, this is what I need to do, we would find a way to get it done. If you need to get it done, that's not what health plans are here to stop to do, as long as the doc on the other side gets and picks up the phone. I do get it that doesn't happen enough, but that part was done. Then technology to support that. What is the one thing we say? We hated the EMRs, we hated the technology. Okay, so let's fix the technology so that the health plan can rapidly take care of the work we're doing. So those 2 pieces were done. So the opportunity then came to basically take a value-based care mindset, apply expansion money to it. So here's where public and private, my foray into Altruista taught me that you can do good in the world and still do it with a private equity backbone, as long as the concept of taking care of vulnerable populations is in there. So the private equity fund that funded Altruista, they came out of Capricorn, and there's Capricorn Health, which was eBay's employee number 1 who invented the foundation. And their core piece was, you have to do good in the world. So the fact that we were a Medicaid-based application, that was the strength, definitely fit with my mindset. Coming to Care About, and the mindset is vulnerable populations, Medicaid, Medicare. Commercial comes along with that, but even those commercial patients are a lot of blue-collar patients. Can we find ways where the doctors who had just gone through COVID, who had just seen how hard it is to run a practice, practices were closing, what's the model that's going to work? And it is built into exactly what we just said, a combination of single TINs, IPAs, and SINs. Doctors need those structures to move forward. We can't live in a world where you're working on a 70% overhead. That's 1. 2, all of you don't have kids who are going to go into medicine. So the asset that you've spent your entire life sometimes developing, what do you do next? You sell the practice for usually maybe some money when you're towards your retirement, but that means you've spent 50 years, 30 years practicing. and maybe nothing comes out of it, nothing, because 4 people could put a practice right across the street, or the hospital wants to buy it out and buys it 3 years later, spits you out of the system because they no longer need your services. All of these models didn't make sense to me. So Care About's model has been, after taking care of the patient, the next most important stakeholder and shareholder should be the provider. So we've had the ability to go in New York, New Jersey, Florida, and actually invest and support singleton practices or IPAs where we see the sense that they're already thinking value-based care. So you have to be doing that. We love the idea of working with vulnerable communities, Medicaid, Medicare, dual eligible. Commercial automatically comes for the ride, is like the way I say it, because docs usually have a big batch of commercial patients. So we can invest in the practice. We also have our own MSO that helps train, just like this conversation we had. I'll do this with doctors who are actually in the practices and say, how can we enhance our value-based care process? And then I also spend time working with the payers because I understand what they're looking for. So making that payer provider partnership. And then we also, in different regions where they need contracting support, can invest in IPAs. So I feel like this, working in Care About as the chief strategy officer, lets me merge all of the knowledge I've had between a payer and provider support arm in value-based care.
And when you say invest, are you talking about capital investment in the venture capitalist model, or?
It's capital investment. Everyone gets shares in the practice model. Usually it's an MSO build out, and you invest in an MSO and everyone gets shares in this process. So it's the standard way that many other practices are doing. The difference is we don't go in and change your name. You are still you. Still do what you're doing. It's just that you become part of a bigger group of people and you bring your skills to bear. Kiwi said before, it's the attribution. The larger the attribution, the strength in numbers happens.
And do you do pediatrics only practices, or are you more focused
Both.
on Medicare?
Internal medicine, peds. I would call us 70-30 primary care. So family practice, peds, and medicine are the 3 that we like to find. We're going to keep trying to keep that. What ends up happening is after a few years, people end up finding that there's a paucity of available practices. We're not seeing that. I think the model we're bringing to the table to support folks is people like it. So 70-30 primary care.
And do you get to keep your own EMR, or do you have to change over to what you guys are using?
That's a great question. It's a great technology question. In the days of FHIR APIs, where your EMR is a skin in front of data that can talk to each other, which in the next 3 to 5 years, right? If you get a chance, and then maybe you should maybe one of the next podcasts to have somebody talk a little bit around the new standards that are coming up. But the federal government during the Trump era did one really important thing, which said the HIEs didn't do what they were supposed to do, which was connect all of us together. So they forced a standard called FHIR, which all of the EMRs have to do. So conceptualize your like you could use Hotmail or Gmail or Yahoo. It's still mail in the background, right? It's just 3 skins.
Or even a better way of explaining that is you can use Safari, you can use Bing
or Edge
as your web browser, but basically that's just the interface.
Correct.
With the net.
So we're turning EMRs into a skin where the data in the back connects. If we can get to a point where the data in the back will connect faster, no, you shouldn't need to change your EMR. However, we are not there today. I believe what I just described to you will still take 6 to 10 years, but I finally see the light at the end of the tunnel, that the federal government's push for this, making EMRs. Epic is the best example. Epic was the biggest standout. They were completely saying, we're not going to do this FHIR standard. I love the fact that the Trump administration walked into the Epic offices and said, no, you have to do this. Otherwise, we will come after you for your monopoly on the hospital system.
Absolutely.
So yes. They really made everybody build this together. And I like that. And I don't mean to, I think Epic's a great EMR. The point is, every one of these EMRs are doing a good job of what they're doing, but the interconnectivity in the background should make it so that the front end of the EMR is the one I like. If this one works for you, wonderful. If that one works for you, wonderful. In the back end, if they talk to each other, Why should we need to change it? So
So,
sorry
it's
for the long-winded answer on
no,
that.
no, that's a wonderful answer because it's very interesting to watch. For example, modernizing health. I think it's the name of the company. It's out of Boca Raton.
Mhm.
Does a great job with EMR, especially for ophthalmology and I think dermatology. Awesome product, very expensive, but they don't have a real good RCM system to
Mhm.
back them up. In finding it, you understand this from the technology side. When you build code is like having built a house in the 1950s.
Yep.
The copper is still in it for the hot water, and there is no cat wiring through the walls to connect your computers with. And at some point, you can't really add on another room or rig this thing or rig that. You got to bulldozer the house, leave the foundation, and build a whole new thing. And in tech, that's very, very expensive. So we get all these legacy now, which is funny. They're not even 10 years old, but legacy players who don't want to spend the millions of dollars to make their product top, and they don't interconnect. So you get billing services like CareCloud, which was built in the last 10 years. It's totally web-based, and they have integrated so many things that others haven't to your RCM, which is amazing, right? They already have the UPS interface. So when you type in a patient's address, it validates it or invalidates it. Little things, they have all of the CPT codes, and you just say, I want to bill 200% of Medicare, and it calculates it for you. It's two places in the functions, and you're done. You don't have to import it. They have all the NPIs for the country. So if you type in George Rogu as your referring doctor, it already populates the NPI for Dr. Rogu. And all those little things count a lot when you're dealing with 500 patients in a day in a clinic. But it's so expensive to build it onto a legacy one.
Right.
That FHIR standard will allow you to pick the best solution for you in different modes and interconnect them and have a really great functioning IT, which has not been possible in medicine yet.
Yeah. That being said, the majority of the time, like I said, I completely agree with it. The majority of the time, what we're finding is people do eventually go into one EMR because pulling the data out for quality or pushing the data in so that we can take something that's from outside and put it at the point of care. So as you're seeing the patient, we want to affect a gap closure or doing an immunization or some reminders. Right now, it's easier to do it on a single EMR. Hopefully it'll change.
Yeah.
But they do have products out there, third party, that can pull 837 files and 835 and then mix them up into a database and then give you pretty pictures of different EHRs.
But you have to be willing to then Power BI overlay it or work your own. So you're an analytics driven doc who's willing to go to what we call it. There's a left screen where you're watching the EMR, and then there's a right screen where you have the analytics. You're a doc who's willing to live in both of those screens at the same time. That's value-based care medicine. Not every doc does that. Many want to actually see it only in the EMR. And that's the issue we have. That's the current tension, and it's a good tension, is do I live in the EMR or do I find a way to put it together and to put it in two separate screens but still get the work done? I can find you practices that are in both worlds, and at CareAbout, that's one of the things. We have to be able to support both. You can't sit there and say, well, that doc, 2,000 attributed patients. No, they got to get some work done. If we don't help them and they want to see it even in a paper form, we'll print it in paper.
Wow.
Yeah.
Got to support you. This is your practice that we're trying to empower and improve in this process. So that's what I like. So like I said to you, it's my current role lets me merge a lot of what I've learned along the way and help.
Yeah.
Well, this has been a fascinating hour, and I'm very grateful for your time, especially before the big Thanksgiving weekend.
No
I have one more ask of you. One of my dreams is to stand up a mastermind of doctors like you, and have a data mastermind where people who do see the data and the value in population health get together, and discuss these ideas. Because as you mentioned, as you get older, we learn better from peers, and those relationships have really a lot of value. So we're trying to aim for the first weekend in March in Miami. To many of our guests in this podcast and our friends at Peds United will be getting together in Miami. So pencil that into your schedule. And if there's any chance that you're available, we would love to be with you then and talk about data and analytics and healthcare systems and IT with other leaders in your industry.
Happy to join if I can make it. I'd love to spend a weekend in Miami in the middle of the winter. Sure.
Great. Until then, be safe and have a happy Thanksgiving. Thank you for your time.
Bye-bye.
Bye-bye.
Thank you for listening. This has been a production of the Pediatric Lounge. On the show notes, you will find links to our co-host and other important notes, as well as a timetable of the topics discussed today. Don't forget to follow us on social media and subscribe to wherever you listen to your podcast. Leave us a great review, as it helps us greatly. In the meantime, we will see you next week. The Pediatric Lounge. The conversations are not intended as medical advice, and the opinions expressed are solely those of the host and the guest.